Hello, my name is Scarlett. I'm a Maryville University student. I'm going to be performing a cardiac and a respiratory assessment on my patient Travis. Okay, so look at Travis's anatomical landmarks. His trachea is midline, it is symmetric. His suprasternal notch is visible, as well as his costal angle and the angle of Louis. Okay, turn around please. Also, his costal angle here posteriorly. Okay, great. Now, I'm also going to inspect the patient's chest. Turn right here for me. It is symmetric, chest is symmetric. Ethnicity of colors with his ethnicity. No cyanosis of his lips, and see your fingers. No cyanosis noted in his fingers. Okay, refill is less than 3 seconds. I don't notice any clubbing, which is all normal findings. AP diameter, laterally, I would say about a 1, as opposed to anteriorly about a 2, which is normal. That is what we expect to see. His breathing looks relaxed and effortless. I don't hear any audible sounds of wheezing, no use of accessory muscles, no superficial veins on the chest either, which is again a normal finding. No prominent ribs, everything within normal limits so far. I don't notice any sinus in the body at all, or any rash noted. So I'm going to palpate his chest for tenderness and crepitus. Is it tender? Great. I didn't feel any crepitus either. If there were crepitus, which is that crackling sensation, that could possibly mean there was a pathological condition, which there is none. So I'm going to look at thoracic expansion, anteriorly and posteriorly. So when I have the patient breathe in for me, and exhale. In, exhale. Have you turn around? Let's do this posteriorly. The costal angle. Okay, breathe in. One more time. Turn back around to the front for me. Perfect. So symmetric, his thoracic expansion is symmetric and is equal bilaterally. So we're looking at what's called tactile fremitus. So this is a subjective finding for lung consolidation to assess that. I'm going to say 99 every time that I touch your chest, okay? Right. Okay, turn around to the back, please. Perfect. Turn back around to the front. So tactile fremitus wise, symmetric on both sides, and that is again a normal finding, is to be expected. So I'm going to do some percussion on the patient as well. I'm going to have you, we're looking for resonance, which is all over all lung fields, there should be resonance noted. Okay? So percussion. Turn back for me, please. So anteriorly, no resonance, or all resonance in all areas. Okay. Posteriorly, resonance in all areas, which is a normal finding. We'll look at your sides here. Go look at your left side. So far, resonance on that right side laterally. Resonance on his left side. Again, these are all normal findings for someone. The intensity is loud, the pitch is low, it's a long duration, as well as the quality is hollow. Again, that's a normal expected finding. Now we're going to assess the diaphragmatic excursions. We're going to be measuring these as well. So I'm going to have you go ahead and turn to the back here. Take a deep breath in. I'm going to have you hold it. I'm looking for the dullness. Okay. All right. I'm going to find the area of resonance now. I'm going to have you take a breath and I'm going to have you breathe all the way out. Okay. I'm going to measure that. Okay, looks to me like that left side there is about a 3.5 centimeter. I'm going to do this, the next area is going to be the right. I'm going to have you take a deep breath in and hold it. Look for that area of dullness. Just right here. Okay, I'm going to take you, breathe all the way out now. There you go. find the area of resonance. Okay, perfect. Great. I'm going to measure this area. Looks again like we're about a 3.5 on that right side as well. So again, the diaphragmatic excursions with the normal limits. So that's again another normal expected finding. Now we're going to go to auscultation. Since he's in this posterior position, I'm going to go ahead and auscultate his lungs. I want you to take some deep breaths for me when I'm listening. Have you turn to the side for me. Vesicular sounds in all areas of the lung field, which is a normal finding. Take some deep breaths for me. Okay, so the right lung, vesicular sounds. Turn to the other side, please. Thank you. Deep breaths. Left lung laterally, vesicular sounds. Okay, turn to the front. Deep breath. Breathe normal. So with the anterior portion of the lungs, I noticed up towards the top, the bronchovesicular sounds, which are normal findings, and the rest of his lungs, there were vesicular sounds. So all these were normal findings within respiratory assessment. Didn't notice any rubs or wheezes, no adventitious breath sounds, no difficulty breathing. Again, normal findings. So we're going to do what's called vocal resonance, and that's going to be by bronchophony. I'm going to say, listen as the patient says 99 in all these lung areas that we've been assessing. And we're going to go from there. Okay, so I noticed a 99 was muffled sounding to me. That would mean that the bronchophony would be negative. I'm going to go ahead and assess this. This is again a normal finding. I'm going to assess this in his posterior chest. 99 when you feel my stethoscope touch. 99. Perfect. So again, the 99 was muffled, and the bronchophony would be negative in this case. And again, that's a normal and expected finding. So we're going to go do the cardiac assessment. I'll have you turn around here for me, towards the front. Now, I didn't notice any jugular vein distension, which is a normal finding. I'm looking here at the apical impulse, the mitral area. I don't see any pulsations, and if there is a pulsation slightly, it should be within 1 centimeter, which is, again is a normal finding. So I'm going to have you lay back for me. So I'm going to palpate his precordium. So I'm going to start here, where I'm palpating his precordium. I'm going to start at the left and right lung bases. The left sternal border. And the apex of the heart, which is the apical area for the impulse. Now, as I'm doing this, I want the patient to make for sure he turns his head to the side. I'm going to palpate the carotid area. And it is synchronous, which is a normal finding. With your apical pulse, you hear, I can feel those exactly the same. So again, that's what we were looking for. I'm going to have you set up for me. I'm going to have you lean forward slightly. Do the same thing. So your right, your left, heart basis. The left sternal border, as well as the left midclavicular line at the apex of the heart. And this, I've noticed, is where the PMI is. That's normal finding between the 4th and 5th intercostal space, midclavicular line. And it's synchronous. I have you turn your head to the side, and I'm going to assess his carotid artery here. Okay, and they are synchronous again, like I said. Perfect, that's a normal finding. So we're going to use what's called percussion. Press the heart. So determine the size of the heart, and I'm going to move from the left axillary line to the left sternal border when I'm doing so, and I'm going to mark that area. Usually we use a chest x-ray to do this, but if you don't have one, this is what you can do manually. Move from resonance to finding dull, which you would mark this area. Okay. Again, left over to the left sternal border. Okay. And you mark where it's dull. So this area you can outline that left side of the heart. You connect your dots and outline to see where your heart is. Also on the right side, you're normally not able to feel that or find that area to palpate it or to percuss it because of the sternum. So mainly if the heart was enlarged, you would be able to find this over on the right side usually. So I'm going to now also take your heart. I'm going to listen for my S1s and S2s and any other adventitious sounds. Let's start at my aortic area. You can breathe normally. It's the second intercostal space. The left intercostal space is going to be a pulmonic area, the second intercostal. Your third intercostal is going to be your Erb's point, the left. Okay. Your tricuspid is going to be your fourth intercostal space. Okay. Now I'm going to have you within the mitral area, which is our apex and PMI of the heart. I'm going to have you take a deep breath in and hold it. I'm going to feel his carotid. Okay, perfect. You can breathe out. So they are synchronous, which is what we were expecting. That's where the S1 is as well. It's systole. So I'm going to have you now lay back. Okay. I'm going to go again, the right border. Or I'm going to get, right base, left base. Left base is your pulmonic area. Your Erb's point is the third. Fourth intercostal space is going to be your tricuspid. And when you get to the mitral area, have the patient take a deep breath in and hold it while I'm palpating the carotid artery. And they are synchronous. In this area, the apex of the heart, you can actually listen to your rate, your heart rate, determine that. Okay. Now I'm going to have you lay on your left side for me here. That's the lateral recumbent position, left lateral. And I'm going to use the bell stethoscope. We can hear actually our sounds, the low pitch sounds the best. I'm going to listen to the same landmarks. The aortic, the pulmonic, the Erb's point, the tricuspid, and again our mitral. I'm going to have you take a deep breath in and hold it. So I did note that in his mitral area and assessing the carotid, they were symmetric, S1, of course, and the no other issues. So that would be our systole. So you can set up for me here. So within listening to his heart, we noticed that we had regular S1 and S2. No adventitious sounds, rhythm was regular. No S3 and S4. No splitting, no variations. No murmurs, clicks, or friction rubs. No snaps. If there was a murmur, what would be included would be, we would note the timing, the duration, the quality, the pitch, the intensity, the pattern of the murmur, also the location, radiation, and the variation with respirations. Again, thank you for watching my video.